Good afternoon, everyone. For those of you who don't know me, I'm Christy Page. I'm the interim chair of UNC Family Medicine and want to welcome you and thank you for being with us here today for our esteemed Huntley Lectureship. So why are we here today beyond this beautiful environment and a lovely meal and celebration of community, celebration of what we have to offer to the mission for UNC Family Medicine, and certainly in celebration of legacy and of a man who gave so generously on behalf of our department. But the main reason we're here today is for our patients. And during this time of major change in healthcare, it's impacting all of us, our patients and our providers and our staff. But most importantly, it's impacting our patients, and it's the patients that have the most to gain or to lose in the future of healthcare in our nation. And it's all happening very, very fast. So exactly what our healthcare system will be is yet to be determined, but it will depend on us making a major impact to improve the system, with primary care clearly being a fundamental focus. And if we do this, then we can actually deliver healthcare at the highest quality and at the lowest cost, and we can increase patient and provider satisfaction as we do so. And so UNC Family Medicine, you are our friends, and so you know this, but we are doing great things to impact our patients and to impact practices across the state and across the nation. We are nationally recognized for developing innovative programs and with real attention to practice redesign and true transformation of healthcare. We are also nationally known as being the best in the nation in our training programs and to train the next generation of healthcare leaders, many of whom are in the room with us today. And our emphasis remains on care of vulnerable populations and on taking care and providing the best care for all patients. But we have no delusions that we can do that alone or that we have all the answers. And we have many additional guests in the room who have expertise in this area, and we're delighted that we can work together and learn from one another. This particular lecture is very important to our mission. I think it was over 13 years ago that Dr. Joan Huntley here, along with Warren Newton here at this table, saw the need to bring new ideas into UNC and to be able to share and cross-pollinate. And it was developed in the name of Dr. Robert Huntley to create this visiting professorship and lecture to be able to forward ideas and to recognize him as a great physician leader. But it's also made possible, and I want to be sure to give attention to the vision and support of an equally great researcher, leader, and friend, Dr. Joan Huntley. And I want to take a moment to just acknowledge that I've appreciated very much getting to know you better, Joan, and the opportunity to get to know her and realize that she was really a pioneer epidemiologist and woman leader, and someone that has inspired me personally to grow and to serve as a woman leader in healthcare. Private giving is critical and a crucial catalyst for us to transform healthcare, and so we do want to appreciate our alumni and friends who continue to give to UNC Family Medicine, to the Medical Foundation, and it's through your giving and your continued giving that we're able to make such forward progress. And now let's get to our Huntley lecturer. We are so delighted to have with us Dr. Thomas Bodenheimer, who is described for you in your program many of his accolades. He's a very understated and humble man, especially considering his record of service and of leadership and of research across the nation. He received his medical degree at Harvard and completed his residency at UCSF. He spent 32 years in full-time primary care practice, and he's currently Professor Emeritus of Family and Community Medicine at UCSF. He's the founding director of the Center for Excellence in Primary Care. He's written numerous journal articles and books. He's published in the New England Journal, JAMA, Annals of Family Medicine, and Health Affairs. He's known for many things, but many of us in the room have enjoyed his work around the building blocks of primary care, his work around MAs with staff and teams and how that works to improve patient experience and patient satisfaction. And he's most notable most recently for the seminal article that he co-authored on the quadruple aim, called From the Triple Aim to the Quadruple Aim, the care of patient requires care of the provider. So without further ado, I will welcome Dr. Tom Bodenheimer.
Thank you, Christy. Can everyone hear me in the back and in the front? Okay? Not okay? Okay. We're going to cover a lot of ground. So hold on to your horses. Here we go. So we're going to talk about primary care and its value, challenges to the healthcare system, and then specific challenges to primary care, and then solutions to those challenges, which of course will be the best part. So what is primary care? So if you're a patient, it's where I go first when I need care, which is what we call first contact care. I see the same provider whenever I need care, which is continuity of care. My primary care provider takes care of most of my medical needs, which is comprehensiveness. And if my primary care provider can't solve my problem, she coordinates my care with specialists, hospitals, and other services, which is coordination. And these are the great 4 pillars of primary care put forward by Barbara Starfield, who was a pioneer of primary care. But there's another important primary care pioneer that I want to mention, Dr. Huntley. He was a pioneer at the dawn of family medicine, which is around 1969. And I've read all of his articles, and they are amazing. Number one, they could have been written today. Number two, I learned a tremendous amount from reading those articles. So I recommend Dr. Huntley's articles to all of you. So why do we think primary care is so important? Well, a lot of research has shown the reasons. Patients with regular primary care compared with those who don't receive more preventive services, better chronic care, adhere more to treatment, and are more satisfied. Patients with good primary care have lower costs and better outcomes than those without good primary care. People with a regular primary care practitioner has lower costs. And this is, to me, the most amazing study. It was done by Becker and Chandra a few years ago. If you look at all of the 50 states in the United States, and you look at a whole bunch of clinical outcomes, and you look at costs, for Medicare patients, states with more primary care physicians per capita have higher quality and lower costs, and states with more specialists and fewer primary care providers have lower quality and higher costs. A landmark study. So let's move on to the challenges. And first, the challenges of the bigger healthcare system, and then challenges of primary care. So you all know that the triple aim is improving the health, enhancing the patient experience, and reducing per capita costs. And the fourth aim is improving the work life of healthcare providers, including clinicians and staff. So how are we doing on the quadruple aim? So improving the health of populations. So if you look at most of the data from the last number of years, death rates have been declining by nearly 2% per year. So that's the good news, but there's bad news. This is the first time in a long, long time that actually a group of people's mortality rates have gone up. And these are mortality rates of middle-aged white adults, particularly with a high school degree or less. And their overall mortality has now been climbing rather than decreasing. The main causes of this increase in mortality are drugs, alcohol, and suicide. And further extension of this research shows that between 1994 and 2014, US death rates for white adults between 22 and 56, especially in the Southeast, Appalachia, and the Rust Belt, have been increasing. This is a big problem with the first of the triple aim, which is the health of the population. We need to address it. The patient experience of care. Now, it's interesting that if you were in a healthcare system and you ask people, do you like your care that you get at UNC Family Medicine or my hospital, San Francisco General Hospital, they usually say, yeah, they like it pretty much. But if you do a national telephone survey, we get quite different results. So, percent of people in the national telephone survey who say that doctors can be trusted, 58%, not good. Percent that are satisfied with the recent doctor visit, 56%. Confidence in the whole health system, 23%. We have a lot of work to do on the patient experience of care. More bad news, costs. I don't have to tell you about that. And then the fourth aim, which is improving the work life of healthcare providers, including clinicians and staff. So this was a survey about 10 years ago of general interest in family docs. 27% were burning out and 30% said they were likely to leave their practice within 2 years. And then this was redone, 2014. Now 54% of physicians are reporting burnout. So why is that? So there's a recent article by Chris Sinsky in the Annals of Internal Medicine, which is very disturbing. They directly observed 57 physicians in family medicine, internal medicine, cardiology, and orthopedics offices. Only 27% of their total time at work was face time with patients. 27%. But it's even worse. Of that 27%, 1/3 of the time when they're in the room with the patient was looking at the EMR and doing desk work. So really only 17% of the total physician's day is spent on doing the things that we all wanted to do when we became physicians, which was to take care of patients. In addition to that, 1 to 2 hours on average of after hours work with the electronic medical record. You can see why burnout is so high. So let's move on to challenges to primary care. I'm going to just list some of the challenges, then give a little more detail about each one. Seriously underfunding, poor access, small percentage of medical school graduates entering primary care, panel sizes too big, burnout we've talked about. And the question is the primary care cliff poem falling off the cliff? And I used to think, probably about 10 years ago, I was pretty discouraged about how primary care was going. In the last 10 years, I've realized that primary care is actually doing very, very well, given all of these challenges. And we'll talk about why it's doing so well shortly. A little bit more about the challenges. So we have a $3 trillion healthcare system. Only 5% of those dollars go to primary care. So most developed nations have a healthcare system that looks like that. Primary care is the strong base of the healthcare system. How do we look? Primary care is kind of a wobbly healthcare system and sitting on the edge here. The United Kingdom spends 8% of health spending in primary care. So that's not that much more than 5%, but if you put it onto a $3 trillion budget, that's tens and tens and tens of billions of dollars that could go to primary care if we increase the percent of the healthcare dollar that went to primary care from 5 to 8%. Access to primary care, again, it varies with where you are. But if you compare the US with an excellent healthcare system in the Netherlands, people who have no same-day access, about twice as high in the United States as in the Netherlands. People who have trouble getting after-hours care, also about twice as high. So how about the supply of primary care physicians? Demand is going up, and the supply, unfortunately, is not going up of family docs and general internists. So there are 8,000 new primary care physicians that enter the workforce each year. 8,000. How many retire each year? 8,500. We got a problem. So there'll be a shortage of about 17,000 primary care physicians by 2025. And we'll talk about solutions to that problem when we get to our solutions part. Now, actually, if you look back, the primary care physician shortage is not a new phenomenon. 1931 to 1962, PCPs per 100,000 populations going down. Who uncovered that? Dr. Huntley in one of his papers. Panel sizes are too big. So your sister family medicine department at Duke uncovered this data, which is that a primary care physician with a panel of 2,500 average patients would spend 7.4 hours every single day doing all recommended preventive care. If you're a perfect preventive care doctor, that's how long it would take if you have that big a panel. Plus another 10.6 hours for chronic care. Not possible. That is not a doable situation. But this is primary care docs working alone without a team. We're going to talk about how a team could change that in a few minutes. So summarizing the challenges facing primary care, 5% of the healthcare dollar goes to primary care. Many patients have trouble access. Panel size is too large. The worsening shortage will mean the panel sizes will get bigger and not smaller. That means poor access to patients, more physician burnout. Some people think it's going to be a downward spiral. I absolutely disagree with that strongly. We are going to solve these problems. We're going to take care of these challenges. Now, I apologize that while you're eating lunch, I've caused you to be seriously depressed by all the things I said. But I hope that the second half of what we talk about will allow your PHQ-9 scores to go down. So don't give up. Sorry for the bad news. We're going to feel better soon. This is my grandson. He's feeling pretty good. Okay, solutions. There are solutions that are macro system solutions in the big system, and there are microsystem solutions within the primary care practices themselves. Let's start with the macro system solutions. There's a lot of money in our healthcare system. Sadly, about a third of it is wasted. And a lot of the waste is specialty-driven, unnecessary care that can also harm patients. Now, do I dislike specialists? No, I was in practice for 32 years. I relied on and worked with many, many wonderful specialists. But if you look at the data, there's no question that there's a lot of care that tends to be driven by specialists that is unnecessary and also could be very harmful to patients. And again, look at this article. Very, very early, Dr. Huntley realized that over-hospitalization is not only costly, but it can be hazardous to your health. So what's the solution to the problem of the 5% underfunding, not enough money going into primary care? Well, there are places that are actually changing that, and they tend to be integrated delivery systems. So Geisinger, Intermountain Healthcare in Utah, Group Health Cooperative in Seattle, they have about 13% of the healthcare dollar going into primary care. So it is possible to put more money into primary care. And one very interesting intervention on this was done by Chris Collar, who was insurance commissioner of Rhode Island a few years ago. And as insurance commissioner, he said to the insurance companies, you have to put more money into primary care. Now you put 6%, you got to increase it by 1% per year. So what happened is the percent of insurers spending on primary care in Rhode Island went from 5.7% up to 9.1%. There are things that one can do to increase the amount of money going into primary care, and I think we all feel like we need that. So what are we going to do about the shortage of primary care physicians? Well, there are really two strategies one could think about. One is say, well, there's nothing we can do about physicians. Let's just focus on nurse practitioners and physician assistants to narrow the gap. That's one strategy. The other is let's really try to increase the percent of medical students and residents going into primary care. And that's going to require a lot of change. Number one, we have to narrow the income gap between procedural specialists and primary care physicians and cognitive specialists. Publicly financing medical education, reimbursing RNs, pharmacists, and other team members to reduce physician stress so that medical students going into primary care practices can see that actually physicians have a reasonable life in primary care. In my medical school, UCSF, we have a culture that is not favorable to primary care, and you'll hear the few of our graduates that go into family medicine tell us that they were told by a number of their professors, you're too smart to go into family medicine. I know that couldn't possibly happen at UNC. And finally, when medical students go to teaching clinics in their third year clerkship for family medicine and they see the teaching clinics not working well, they decide, well, maybe I don't want to do primary care, maybe I should do something different. So we have to fix any kind of dysfunction in our teaching clinics. And I've spent some time in the Family Medicine Center here, and I must say that is a clinic where I would be very happy if I went there as a medical student to pursue a primary care career. Congratulations. There are other ways to try to increase medical student going into primary care practice, and you have a program here that's just starting, which is the first program. So candidates are picked for commitment to primary care careers, reduces their medical debt, provides loan repayment. Medical school is shortened from 4 to 3 years, and they have the opportunity to be in the UNC Family Medicine residency. And then they have to be committed to 3 years of primary care practice in underserved areas of North Carolina. It's a wonderful idea. Good luck with it. I hope it goes really, really well. Let's say that we fail and we can't get more medical students to choose primary care careers. What about nurse practitioners and physician assistants? Practitioners, there are now 18,000 nurse practitioners who graduate each year and 7,500 physician assistants. Now, not all of them go into primary care. Nurse practitioners about 50%, PAs about 32%. But just look at these curves. For physicians, it's kind of going a little bit downhill, the percent of new entrants into the workforce. Nurse practitioner is just growing by leaps and bounds. Physician assistants, not quite as much, but also a lot. So if you look at the percent of primary care practitioners who will be nurse practitioners, it's going up like that, and the percent that will be physicians is going down. So nurse practitioners are really, to a large extent, primary care of the future, which is a good thing. Okay, we've talked about macro system solutions. How about solutions within our primary care practices? Our philosophy at the Center for Excellence in Primary Care is that we learn from the bright spots. So we know that with everything in life, there are people and things that work really well, and there are things that don't work well at all. It's the same thing with primary care, and we really need the bright spots to help people who are struggling to get better. So a lot of the work that we've done is to look at bright spots. And that's one of the reasons I really wanted to come here, is to look at the Bright Spot Family Medicine Center at UNC. So we looked at 23 practices that were high performing all around the country. These were not teaching practices, these were non-teaching practices. And what we found is that we had some FQHCs, we had some small private practices, we had practices within big delivery systems. So they look very different from the outside, but from the inside, they look very much the same. They have all implemented a certain set of reforms to make their practices work well. And we call those the 10 building blocks of high-performing primary care. So what it means is, excellent primary care exists all over the United States. It's here. So the future is here. The problem is it's unevenly distributed. We have to distribute it to everybody. So these are the 10 building blocks of high-performing primary care. I'm not going to go into all the building blocks because you'd be here for a very long time. We're really focusing today on teams, our fourth building block. Do teams improve outcomes? We didn't really know until last year. So Intermountain Healthcare in Utah, which is a system with many, many primary care practices, they've developed very high-performing teams in 27 of their practices. And these teams, in order to be called well-developed and high-performing, they have to be in existence for at least 6 years. It takes time to build a good team. Then they compared those with 75 non-team practices. The patients in the team practices had more depression screening, higher performance in the diabetes care bundle. In other words, more A1C control, more LDL control, more blood pressure control. They had lower rates of healthcare utilization, ED visits, hospital admissions, and lower total cost of care. It's a landmark study. It was in the JAMA just last year that show that teams, high-performing teams, really can make a difference on the quadruple aim. So when we've gone into these practices, these high-performing primary care practices, what we've noticed is that many of the teams are broken down into a core and then a more extended care team. So the core is usually a clinician. By clinician, I mean doctor, nurse practitioner, PA, and a medical assistant working together, and they are taking care of a patient panel. And around 3 of these teamlets that we call, there are other people that support those teamlets for patients that need more services. That's not the model in every place, but it's a very common model in non-teaching practices. I just want to give you a picture of a high-performing teamlet. Here's another one. So the other thing that we found is that these teamlets and these teams tend to be stable. So what do we mean by a stable team or teamlet? The same people always work together. Patients who are impaneled to that team or teamlet are always cared for by that team or teamlet. And the teamlet is responsible for the health of its patient panel, and it only sees patients on its panel. So really the patients are impaneled to a teamlet or impaneled to a larger team. So that gets to the question of what do patients want from physicians, and the research really is about physicians, but I think one could extend it to NPs, PAs, RNs, behaviorists, physical therapists, medical assistants, anyone on the team. So what are the things that patients really want from that team? They want competence. So in the research, it's I want my physician to have the knowledge needed to help me. Empathy, I want my physician or team to care about me. Familiarity, I want to know the people on my team, and I want the people on the team to know me. Very important for patients. And finally, continuity. I want to see the same team or the same physician every time I need care. Those are things that in research studies, patients have said are really important for them. Which goes back to why it's important to have stable teams. Number one, patients' familiarity. I want to know the people caring for me. If a team is constantly shifting, they're going to deal with too many people, and it won't be comfortable for the patients. We've done some studies at UCSF that shows that clinicians working with the same MA every day tend to have lower levels of burnout than clinicians working with different people on different days who really know stable teams. It seems to make a difference. Finally, we know that patients like small practices, and we know that primary care, the practices are getting bigger and bigger and bigger. So what a small team can do is to divide a practice down into small units so that the patient feels like they're going to a small practice, even though they're actually in a big practice. This is an example of a very good healthcare system, the Bellin healthcare system in Wisconsin, that has a 3-person teamlet structure where there are 2 care team coordinators that tend to be medical assistants who are working with each clinician, and they're doing panel management, making sure all of the complex, the chronic care and preventive care needs are met. They're doing health coaching to help people with their behavior change, and they're scribes, so they're taking care of all the EMR documentation. Beautiful system, and we have a write-up on that system if you want to contact us or look at our website, Center for Excellence in Primary Care. The other thing that's been happening recently, or not so recently, is extending teams out into the community. So let's look at the Vermont Blueprint for Health. Really a fascinating experiment in how to organize primary care in an entire state. So in each region of the state, there's a community health team. The community health team is outside the primary care practice, but it supports the primary care practice with RN care managers, social workers, health educators, and community health workers. So it really extends the scope of what primary care practice can do. And the insurance companies in Vermont are funding the community health teams, and it's turned out to be a good return on investment because it's saving a lot of money in healthcare costs. And then right here in North Carolina, Community Care of North Carolina has extended the primary care teams into the community with your care management program, which assists about a couple of thousand primary care practices to improve care and reduce costs for people with chronic conditions in your 14 regional networks. A very, very impressive work to extend primary care teams out into the community. So in these practices, we looked and said, what are the elements of high-performing teams? And we found a number of elements, which is listed in the article we wrote recently, and I'm not going to talk about all of them. We've talked about a stable team structure and how important that is. The other part is what we call the culture shift, or sharing the care. So sharing the care really means from I, the clinician does everything, to we, the entire team, shares responsibility for the health of the panel. And sharing responsibility doesn't mean that a physician's going to tell that medical assistant, you should do an EKG, or you should take care of this, look at this patient's glucose, blood draw. That's tasks, and they're important, but sharing the care is responsibilities. So a different way of thinking of it is the medical assistant is responsible to make sure that the entire panel of patients that they're responsible for has all of their cancer screening done on time and has all their immunizations on time. It's a responsibility that they feel like I'm really helping the health of my panel rather than just doing tasks for the clinician. So it's more like they're helping the patients rather than helping the doctor. The other thing that happens with sharing the care is not only are you thinking about the patients who come in today, but you're thinking about your entire panel and how to make that entire panel healthier. So why do we build teams that share the care? Why is sharing the care so important? To improve access, which we're going to talk about, to reduce provider burnout so that everyone contributes to the care without necessarily making the physicians work more, to improve quality beyond what a provider alone can provide, to create a comfortable small practice environment for patients that we talked about before, and to engage everyone in the practice to contribute to patient care in a meaningful way. I want to just give one example of improving quality beyond what a provider alone can accomplish from the Vermont Blueprint. Remember the rising death rates for middle-aged white adults to drug, alcohol, and suicides. Well, the Vermont Blueprint added addictions and mental health counselors to community health teams and certified many more physicians in buprenorphine. And hospital admissions to ED visits for opioid use decreased. We don't yet know whether drug overdose deaths decreased in Vermont, but we do know that they significantly increased in other New England states, but not in Vermont. So it's still early to see exactly what the outcomes of this are. It's an example of how a team into the community can do things that maybe the primary care practice doesn't have the resources to do. I want to spend a little time on access, because access is the thing that patients complain about the most, though apparently not here at the Family Medicine Center at UNC, but you're an exception. So good access means that demand for care has to equal the capacity to provide care. So let's do a little bit of mathematical exercise here. I think you have enough lunch in you that you can deal with this. So demand for one practitioner is the panel size times the number of visits per patient per year. So let's say that you're a doc and your panel size is 2,000 and your average patient comes 3 times a year. That's 6,000 visits a year. That's the demand for your care. Now this is oversimplistic because it's only demand for face-to-face visits, but let's just keep going with this exercise. What's the capacity for one physician? So if you work 200 days a year and you see 20 patients a day, your capacity is 4,000. Uh-oh, we're in trouble. There's a demand capacity gap of 2,000 visits. So how do we close it? Well, it's easy. Have practitioners work more days per year, then the gap is only 1,000. Have practitioners see more patients a day. Fun. Now the capacity is 6,000. Okay, we've closed the demand capacity gap. How many people think we've solved the problem? Uh-oh, burnout. So we reduced the demand capacity gap to 0, but all the practitioners quit, so now we have no capacity at all. So let's try a different way. So let's talk about practitioners, non-practitioner licensed personnel, RNs, behaviorists, pharmacists, physical therapists, and non-licensed personnel, which are mostly MAs. Now, the next few things I'm going to talk about, I know all of you, because everyone does this, are going to say, we can't do this, it's not possible. So I'd like you to take the barriers to doing the things I want to talk about, and put that kind of in the back of your mind, kind of put it in the parking lot. I know the barriers are there, but let's not think about them for a while. And the barriers, of course, are we can't recruit the personnel we need, only practitioners are reimbursed, we don't know when the alternative payment mechanism will arrive, there's no time to train or mentor staff in enhanced roles, and scope of practice laws. Are all these real barriers? Yes. Let's look at the next few minutes. So let's assume that you have a panel of 2,000 patients, creating 6,000 patients visit per year. And let's say, just for a mathematical exercise, that 1,000 of those visits are for diabetes, 1,000 are hypertension, 1,000 for uncomplicated low back, knee, and shoulder pain. Just to make things simple. And let's assume that RNs, pharmacists, and physical therapists can actually independently, without taking any clinician time, take care of 2/3 of those 3,000 visits. So non-practitioner visits, 2,000. Practitioners, remember, are 4,000. So we've closed the demand capacity gap by sharing the care with licensed personnel. So then the question is, can nurses, pharmacists, physical therapists, and behaviorists really do these things? Well, the evidence is very strong that they can. So let's take RNs. This was a randomized controlled trial. Patients with diabetes and elevated blood pressure. Patients with RN management. I want to make sure I got the right time. How are we doing for time? 12:35. We're doing okay. Patients with RN management, including initiating meds and titrating doses, which actually is possible in some states, given standardized procedures. The RN management is 3 times more likely to reach blood pressure goal. Does that mean that nurses are better clinicians than doctors? No. What it means is that the average number of visits of patient agenda items in the 15 to 20-minute visit is 7.1. Now, how can you do 7.1 things in a 15 or 20-minute visit? Well, of course, treatment of blood pressure is probably going to be way down on the list and won't be taken care of. So the RNs have more time to do this kind of work. And similarly with pharmacists. Pharmacist management of hypertension compared to physician management at 18 months, 72% blood pressure control for pharmacists, 57% in the usual care group. So the RNs and pharmacists can actually do this work independent of physicians with excellent quality. Patients with uncomplicated musculoskeletal injuries who directly access physical therapists without seeing a physician have better functional outcomes, greater satisfaction, and lower healthcare costs. Now, if they go to the physical therapist first, and if the physical therapist notes that there are red flags, then it goes back to the clinician rather than the other way around. It saves a lot of time, and as you can see, quality is good. Behaviorists working with depression care managers can improve outcomes and can reduce the number of physician visits. So all of these team members, if you really empower them to do what they're capable of doing, can improve capacity without increasing burnout. We also know that complex care management teams can be successful in reducing costs and improving care for people with multiple diagnoses, high needs, high costs, and so forth. There's a bunch of evidence, and there's more evidence being accumulated than this every single day. So how about non-licensed personnel? How about medical assistants, for example? We know that medical assistants can very well, and they do it right here in the UNC Family Medicine Center, identify patients overdue for routine, chronic, and preventive services, and arrange for those services to be performed. That's immunizations, cancer screening, diabetes care. There's also research that shows that the quality improves. And again, the quality improves because remember the 7 agenda items in the physician visit. Preventive care is going to go down to the bottom. So if you have someone else doing it, who's doing it well, more preventive services will happen. And with more screening, we're going to catch more early cancers and outcomes will improve. Health coaching. So we've trained a lot of medical assistants to be health coaches, helping patients to develop the skills, knowledge, and confidence to become informed, active participants in their care of their chronic illness. We had a randomized controlled trial. MA health coaches did much better than patients without coaches in reducing their A1C and LDL cholesterol. We have a lot of information on our website on health coaching. Now, it's very difficult. Medical assistants really can't be health coaches if there's only one medical assistant per provider. It's just, health coaching takes time, way more time than panel management. But it is something that if you have the personnel, even if it's outside the practice, say in a hospital or in an AHEC or in some other institution that helps primary care practices, or in a community health team, or as in the North Carolina community care, it is possible to have personnel available who could do this health coaching. Scribes. So we know that medical assistants can be trained as scribes. That's what they do with the Bellum healthcare system, and they're very effective in doing all of the documentation, which really helps reduce Chris Sinski's finding that only 17% of the physician's day is spent really on direct patient care. If you have a scribe that does all this documentation, that can change dramatically for the better. So this was a pilot study at UCLA. There are 2 scribes. Amazing finding. In a 4-hour clinic session, 75 minutes of physician time were saved by having someone else do the documentation. 79% of the patients were satisfied. And interestingly, the patients were more likely to report that the physician spent enough time with them. So the physician was talking to them and not to the EMR. Again, the purpose of scribes is to reestablish the physician-patient relationship that has been fractured by the EMR. Here's the doc, not looking at the patient. The patient says, I really like my doctor of over 10 years, but I rarely get to talk to him face to face. As I'm talking, he's typing. Annoys the hell out of me. Hey doc, I'm here too. So let's go summarize what we've said about teams to share the care, to improve access, enhance quality, reduce burnout, create a small practice environment for patients, and fully engage staff in caring for their panel of patients. So these are all of the team members that could, if they can step up to the plate, if we can overcome the barriers to them being empowered to do all these things, we can really improve care without increasing physician burnout. Okay, so here's what we've done. We talked about primary care and its value. We talked about challenges of the healthcare system into primary care. We've talked about solutions. So the question here is, can primary care teams actually help achieve the quadruple aim in the healthcare system? Just reminding you what the quadruple aim is. So let's take each one at a time. Can primary care, high-performing primary care teams help achieve the quadruple aim? The first aim, improving the health of populations. We know that through panel management, which is part of a high-performing team, preventive care performance improves, which translates into better population health. We know from the Intermountain Health study from Utah that seasoned teams are associated with improved A1C, LDL, blood pressure in patients with diabetes. We know that primary care teams utilizing medical assistants as health coaches are associated with improved A1C and LDL levels. We also cited the studies earlier on how RNs, pharmacists, physical therapists, and behavioral health professionals can increase quality, improve the health of the population. And expanded teams have the opportunity to improve population health even more than teams confined to primary care practices because there's more resources available. Okay, let's look at this question. Can high-performing primary care teams help achieve the quadruple aim? Looking at the enhancing of patient experience of care. I couldn't find a lot in this category, but Group Health had a very interesting experiment. In 2006, they introduced team-based primary care, and by year 2, they found that 7 components of patient experience, asking patients a bunch of questions about how they experience their care, improved in the team practices and not in the non-team control practices. Okay, how about improving the work life of healthcare providers, including clinicians and staff? So the same Group Health experiment found the reason that they did this was because burnout was terribly high in Group Health at that point. And in the team-based new practices, burnout went down from 25 to 14%, while it went up in the control practices. And staff burnout also went down in the team-based care practices. There was a small practice in Virginia, Peter Anderson's practice, that created a team of 2 clinical assistants to serve as scribes, panel managers, and health coaches, similar to the Bellum Clinic example. Quality of work life improved for physicians and the clinical assistants. Again, teams can make a difference. Some of the work that we did, this was a survey of 326 primary care providers in 19 practices, with good teams, with a collaborative team culture, teams that really get along well with each other, were associated with lower burnout scores compared with no teams or teams with not a good culture. So teams have to be well-working teams to make these outcomes. How about costs? Group Health again. The team-based care experiment introduced in 2006 was associated in the second year with a reduction in healthcare costs from reduced ED visits and hospital admissions. There was a saving of about $10 per patient per month. So if you have 100,000 patients, it adds up. And again, they were devoting 13% of their expenditures to primary care to achieve these teams. The Vermont Blueprint practices, supported by community health teams, saved $450 per capita in 2014, compared with non-Blueprint practices. And that took several years to achieve also. So again, it seems like teams, if they really work well, and particularly if the teams also extend beyond the primary care borders, they can save money. Here at North Carolina, compared with non-community care beneficiaries, Medicaid beneficiaries in community care of North Carolina saved Medicaid $336 million in fiscal year 2014, and inpatient admissions decreased for people who were in the community care system while increasing for non-community care beneficiaries. And Intermountain Health, remember their teams? So lower rates of ED visits, hospital admissions, and lower total cost of care with high-performing teams. Okay, we've reached the end of our journey, so let's just review the take-home messages. The primary care physician to population ratio is falling, and nurse practitioners are a critical source of the primary care practitioners of the future. But even with nurse practitioners and PAs added to physicians, there won't be enough practitioners to provide sufficient capacity to meet the increasing population demand. So sharing the care with a well-trained team, as we've discussed, empowered with standing orders, can add substantial capacity and improve quality without increasing provider burnout. So is there truly an association of team-based primary care with improvements in quadruple aim metrics? Now, we've looked at some bright spot examples. I don't think we have enough information to answer this question for sure. But it looks like with the if all the practices were bright spot practices, I think we're pretty sure that this can be done. And particularly programs that extend teams beyond the primary care practice. If the cost savings from programs like Group Health, Vermont Blueprint, Community Care of North Carolina, and Intermountain Healthcare could hold up over time, they really create a business case for payers to invest in primary care. Because really to do these things does require some upfront investment. Getting the dollars on the back end, you really need some help on the front end to really get these systems working. But if there really is a business case, the primary care can reduce costs by having these high functioning teams, then it should be possible to increase the number of dollars going into primary care beyond the 5% that currently goes to primary care. So I'm very, very hopeful that primary care can achieve all of these things. And I know that with the people in this room and people in many other rooms like this and many other practices all over the country, we can overcome our challenges and assist the healthcare system, the quadruple aim. So thank you very much. I'm sure that there are no questions because I answered everything. Yeah, okay. I'll let you go. Go ahead.
Thank you for the presentation. Probably for allowing us to hear you. But I've been in practice almost 40 years now, and I have a lot of questions I can ask you. A couple in particular. We talk about having teams and teamlets to serve the community. But we're in a very competitive environment in healthcare, as you know. And quality is thought to be associated with good outcomes. But is that the true definition of good or bad quality? Or is there other metrics that we need to look at where we tell people in the community we've got the best quality in town? You talked about some of them, I think in terms of affordability, accountability, affability, and availability and accessibility, and all those, I would think, are metrics that might be looked at that you could measure and put that on the table when you go to a large corporation or an insurance company and say, this is how we are performing. And then the other question too is, you get a lot of residents, and I feel for you folks that are here. You come in this with a passion. I want to be a primary care doc, a family doc. I want to go out to the community and save the world. And it's going to happen. It ain't going to happen anytime soon. I'll tell you that. Doing this about 40 years, where do you get that inner motivation to keep you going? And what do you do to keep that motivation moving? I mean, I try to exercise, I try to write, reflect, read, but do other things as well. What will keep you as an individual loving what you do day in and day out, taking care of patients? Because that's where it is. Any of those things you'd like to reflect on? You've worked almost as long as I have.
Not quite. Well, first, I just want to congratulate you on 40 years of primary care practice. Those are two hard questions. You know the definition of a bad question? It's one I can't answer. I certainly agree that the traditional clinical quality metrics of percent of A1C under 9, percent of colorectal cancer screening, all of those things, they're very important for improving the health of the population, but they probably aren't the things that are going to attract patients to your health system or your practice. So patient experience with your practice is certainly important. And I think access and continuity of care are metrics that increasing number of healthcare providers are beginning to look at, and certainly the Family Medicine Center here is looking at access and continuity of care, things like that. So and waiting times, there are a lot of things that are, I think, would be more likely to attract patients to a health system or a practice than only things like diabetes and cancer screening. So I agree with you on that. In terms of the inner motivation, I thought I did pretty well with 32 years, but here you are. Primary care is hard, but I think the thing that kept me going was the longitudinal relationships with patients. I mean, I still remember so many of the patients that some of them drove me a little bit crazy, that's true, but I love them. And their families and just all the things. I mean, I still walk through the Mission District in San Francisco and someone will come to me, Doctor, ¿cómo está? And you know, it's the patients that keep you going. I don't think it's, in our practice, we work 6 half days a week. We also did hospital and nursing homes and everything else, night call. I don't think it's possible to work 10 half days a week and survive. I don't know how many days a week you worked actually seeing patients. Wow, that's fantastic. I think it helps people to maintain their inner motivation if they have some space in their lives for other things in their lives. But I think it's possible to be in primary care practice for a long time if you really try to be careful with having some life space in addition to your work. But again, congratulations. Any other questions? Hi.
Well, first of all, as a patient, I'm almost afraid, same way since I'm for stress level here.
One of the questions I would have is you talk about the primary care physicians and the like and the stress that's involved. But one of the things that I thought is very important is the education of patients. Because quite frankly, a lot of the stress that comes is a result of patients perhaps not knowing what to expect, not knowing what they should do, and what the results are going to be when they arrive. And so I guess my question is, how do you see the education of patients as a part of this whole stress?
I mean, of course, there's health education, making sure people understand their disease. And we know very well with people with chronic conditions, the people who understand their disease better have better outcomes than people who really don't understand, because in chronic disease, the patient's really the boss. I mean, all we can do is suggest lifestyle changes. We can suggest taking medications. The patient decides if they're going to do those things or not. So that's really important. And the other thing is teaching people about the healthcare system, which is so ridiculously complicated in the United States. But there's some places that have, you know, very nice brochures, but you know, for like 5th grade reading level, because we know that these things are difficult. That really tries to explain very, very clearly, like what the policies are in your particular clinic, and also there's an increasing use of patient navigators that help people navigate the system and explain how the system works, because a lot of people just get lost in the system. I mean, just walking around the Family Medicine Center, I got lost the last couple of days all the time. So I agree with you, that's really important.
One of the things you did not address was the electronic connection between providers and patients, and also telemedicine. So how do you think that'll figure into the team's care?
So the question was, how about patient portals with emails between patients and providers and the team, and telemedicine? It's a wonderful way to improve access, number one. I know I'm a patient of Kaiser in California. Most of my care is done by emails back and forth with my doc, and it's really easy for me, and it's easy for him. I think it really helps a lot. There's an interesting study, and I don't know whether to believe it or not, but Group Health did a study. They do about 1/3 of their encounters are either phone calls with patients or electronic messages with patients. And they did a study to see how many visits were reduced by having these other modalities of visits, of encounters, and the visits increased. So I think that that's a whole area that we really don't understand very well. Telemedicine is something that, I don't know, in New Mexico, Project ECHO is one of the, I think, the most amazing sort of experiments in how to spread healthcare throughout a very rural state with a lot of very poor communities. So patients who had hepatitis C, there were a lot of them, this was about 10 or 15 years ago, they couldn't get an appointment at the University of New Mexico gastroenterology clinic for like a year. They were so backed up, and then they had to drive all this way. So Dr. Sanjeev Arora there said, let's train all of the primary care doctors and all the community health centers and small practices around the state to take care of people with hepatitis C. So they set up a video conferencing system where every week there's a video conference with people from a lot of different health centers and practices, having a video conference with the gastroenterologists at the University of New Mexico, training them on how to take care of people with hep C so the patients could get their treatment just as well at home as going all the way to the university. And the outcomes, according to the New England Journal article, were just as good in the communities as it was at the university. Then they extended it to many other diseases, and they also not only teach physicians in primary care in rural areas how to care for these patients, but also nurses, community health workers, pharmacists, and so forth. And now this is spread to many places in the United States and around the world. Project ECHO is something to check out. Hi back there.
Hi, I'm not sure if I have loud enough voice.
I think you do.
My husband would not be surprised. I guess my question is about MA satisfaction and burnout. On the one hand, I think empowering them and empowering them is going to bring them more joy in their work, make them feel that their work is more meaningful. But on the other hand, I think workload tracks with burnout, and we see that with physicians. And I worry that as we increase their workload, we're going to see burnout in the MA population. So I guess just putting that question out there, and then thinking about how like satisfaction in the workplace bleeds over. And I stand next to my MA every day. If they're happy, I'm happier. And likewise, when I'm happy, they're probably a lot happier. So whether anyone has asked that question or looked at that.
I think I extend it to all of the non-clinician members of the team. You know, do RNs want to take care of half of the patients with diabetes? I firmly believe that 90% of people with diabetes can be taken care of pretty much by RNs or pharmacists. Do they want to do that? It turns out that RNs and pharmacists actually really do want to do it, though they haven't been given these huge panels that maybe they will mean they won't have as much time. But you know, I worry about when we talk about other people on the team sharing the care, a lot they could get the impression that, oh well, doctors are doing less work, we're doing more work, and doctors are getting paid more than we are anyway, so it's not fair. You're absolutely right, it's a worry. We did find that teams that have a collaborative team culture where people really get along well and enjoy being with each other and work well together and communicate well together, that burnout among medical assistants went down. But I think the question of increasing responsibility is a big question. My hope is, and I can't prove it, is that increasing their responsibilities for a panel of patients where they see that they're really making a difference for a whole group of patients, that would be something that they would embrace rather than just doing more tasks like more EKGs and more. And so I think the MAs need to see what they're doing in terms of their increased, enhanced responsibilities as really helping the patients a lot. But the question is good, and it's worrisome. I appreciate that.
Tom, this beautiful talk. You have great data on your side. You have a comprehensive, coherent way of putting it all together. You're doing God's work. But the healthcare system in the United States is not really getting the message. And I know you think about this a lot. Where do you see the missing links in terms of we just need more cost effectiveness data? I don't think so. What do you think we need to really move this to the kind of adoption you'd like to see?
Wow. Another question that I give me a hard time. You've been known to give me a hard time for 10 years or so, since I know this guy really well. First thing is I'm not sure. Second thing is I think we need studies that are so airtight that the payers will realize that good primary care can really make a huge difference. And that includes the public government payers and includes the private payers. For example, we're all concerned about the 10% of patients that incur like 70% of our the very complex, high cost, high needs patients. We have a lot of good evidence that we can improve their care and reduce their costs. But there's never been a randomized controlled trial to really prove that for sure. And Jeff Brenner is now trying to do that in Camden, New Jersey, and we're hoping that there'll be results from that. I think the other problem is we know that there's a problem with health insurance, whether it's uninsurance or underinsurance. And I'm a big supporter of Obamacare and particularly the Medicaid expansion. But if you look at the individual mandate part of Obamacare, it sort of brought people from uninsurance to underinsurance because of all the co-pays and deductibles, which are a big problem. I think we do have to solve that problem because that access problem, financial access, if that's not solved the way other countries have solved it many years ago, it's going to be really hard to improve outcomes and reduce total costs of care for people because they can't come to primary care on a regular basis and feel like they can afford it. So that's a big political issue that I think has to be dealt with. So very tough question, not a good answer, but if someone has a really good answer, I'd love to hear it.
What does it cost to set up a team initially?
Yes, what does it cost to set up a team initially? That's why I talked about the importance of some upfront funding to help primary care practices really get going. But it's interesting. If you look at practices that are doing really well and you say, do they have the money and the resources to do really well? It turns out that there are practices that have very little staff and very few resources that have organized themselves to work really beautifully. And there are other practices that seem to have an abundance of resources and personnel that are just chaos. So a lot of it is leadership. Leadership at the practice level seems to make the difference. Having resources is a huge help, of course. What does it cost to set up a team? Well, we think that RNs are a really important part of the team. RNs are pretty expensive. We really have to figure out ways that RNs can get reimbursed for their work. It's just things are not going to work well. That's one of these big barriers that I said, please put in the back of your head, but now it's in the front of our heads. But being able to hire RNs in primary care practice in California is like $100,000 for an RN. And that's a problem, but RNs could do so much to improve care and to reduce burnout. So it depends who's on the team, but it does cost something, and upfront investment would really help. Hi.
Hi, I don't need microphone. Wow. I'm with the state chapter of the American Academy of Family Physicians, and I sometimes feel like we're looking for a solution to the problem that would exist if the investment was made in primary care in the first place. So the reason we have a workforce problem is because the salaries are low and the stress and work life is hard and tough. And even in North Carolina, we're seeing fewer PAs and fewer NPs going into primary care for the same reasons physicians don't want primary care. So I sort of say, why don't we quit looking for solutions that put a Band-Aid on the problem and just get that problem fixed with the investment in primary care. And I know that's easier said than done.
It is indeed easier said than done. Yeah, I would love to see that too. But I still think that trying to build teams as best that we can to improve quality, improve access without increasing burnout is something we can still do, even given the enormous constraints that you mentioned and that totally exist. We have to do the best we can, and at the same time, try to get more of the healthcare dollar going to primary care. It's 7 minutes after 1. How are we doing?
Okay, three quick things in closing. First, of course, let's take a moment to respect and honor Dr. Bodenheimer for his time. And secondly, there are pink cards on your table. Please fill these out. They help guide us as we improve our processes for next year and in future years. They're very helpful. There's some pencils on the table, so you can fill those out and just leave them at your table. And finally, I also want us to give equal and wonderful recognition to Dr. Joan Huntley, who established this lectureship on behalf of her husband, and for just the remarkable contribution and inspiration that you've given to our department and to family medicine over the years. Thank you, Dr. Huntley. That will conclude our event. Please stay and mingle and meet one another. And then we'll all head back off to our work to solving the next challenges of primary care.